Okay, really excited to be doing the autopsy of a PCOS female Dutch review. My name is Dr. Joel Rosen, and today I wanted to go over a very common thing that I see with women that are suffering with PCOS-like symptoms, and maybe they've never been diagnosed. And I wanted to shed some light on what it would look like when you do a Dutch test and how it looks in terms of what we look at. What distinctions we have, and then what we do in terms of putting a protocol together and all the things that we need to think of, not just the Dutch test, but we want to know the history. We want to know the subjective findings, what they feel, why they don't feel the way they do, or they should feel the way that they don't, and really get some insights on that. And so today I wanted to share that with you and go over the Dutch test. But first, let's talk about PCOS, because I think there's a lot of misconceptions. You can have 2 out of the 3 characteristics of PCOS. Number 1 is any abnormalities in the regulation of your monthly cycle. They're too short, they're too long, they're short and long, any disruption in that presentation. Number 2, polycystic ovaries, multiple string of pearls, as they like to call it, or other types of challenges with the polycystic ovarian syndrome. And then the last one is any type of glucose or insulin issues or some kind of glycemic involvement. So you can have 2 of the 3. If you don't actually have the multiple string of pearls or the polycystic ovaries, you could still have polycystic ovarian syndrome findings. And what's really interesting is if you're not looking at the glucose levels from a functional range and your insulin levels, and you're not even measuring those, and you're not doing a metabolite hormone test to look at the different androgens. The third one would be some kind of androgen challenges. So you would have a monthly irregular cycle, you would have a polycystic ovarian syndrome, you can have androgen concerns, and you can also have glucose issues. And so anyways, let's look at, I'm going to share with you my screen, and we will look at this test here for us. Where is it? Let's bring it up. Okay, so here it is here. So what we're looking at is we're looking at a Dutch test. Let's see if I can bring it a little bit bigger. And all right, so we're looking at a Dutch test. The first thing that I like to look at is the salivary-free cortisol pattern. And this is actually a Dutch Complete Plus test. So we were looking at the saliva values. And what's great about a cortisol awakening response is you look at saliva when a person first wakes up, you look at it 30 minutes later, and then you look at it 60 minutes after that. And what's really good about that is that's what's called your cortisol awakening response. So you should see ultimately an increase. Let's see if I can draw in here. I'm going to draw. So you should see a nice spiking increase within the first half hour. A lot of the people that I work with, in this 19-year-old female's case, she has a nice cortisol awakening response. Sometimes we want to look to between the high value and the low value, and she's right in the middle. Sometimes we'll see no cortisol awakening response or below ranges. I sometimes see that the cortisol awakening response starts high before they even got up. So we can kind of describe this person. Let's clear all of this. We can describe this person as getting up in the morning and having some energy and having a nice cortisol awakening response. They get a little bit of oomph when they go. And then pretty much what we see is for the remaining portion of the day after the 60 minutes, it starts to fall. Sometimes, however, you'll see people that have a cortisol awakening response where it still climbs after 60 minutes. And as you can see with the normal graph, it should be starting to fall after that 60-minute period. So sometimes you'll see a delayed cortisol awakening response. And that is informative. Like, we want to know, okay, what day of the week was it? Are you stressed? Are you overstimulated? Are you understimulated? How well does it look? And we can see in this individual that it's pretty much for, as far as the salivary component of this goes, she looks normal. I mean, she has a nice awakening response. It kind of comes down throughout the whole day. And then she just sort of has that crash at night, versus the particular rhythm for the normal one should be a more subtle crash. It shouldn't be such a big crash. So I don't know if I would micromanage and say, okay, we got to fix that. Especially, it really depends on what are the main problems. But then the next thing we look at is we look at the metabolized cortisol and the DHEA production. So the way I explain this is the free cortisol is the available spending money, what's available to be spent. Metabolized cortisol is what was available for the whole day, from when she woke up to when she went to bed. How much did she produce for the whole day? And then the DHEA is the one that how much is in the bank account. And that's kind of an unfair analogy, but it works in this case, because what we like to do is we like to say, okay, how much was your free fraction of your hormone? Meaning, how much do you have available to spend, for any particular time of the day? How much did you produce? How much income did you make for that day? And then what's left in the bank account? And a lot of the times we'll see the metabolized cortisol be very, very low. Let me show you what that would look like. So a lot of the times we'll see the metabolized cortisol be somewhere over here. Like you can see the diagram is right here. Sometimes we'll see it be over here. And if that's the case, I know that that person has a shutdown HPA axis. They have a negative feedback where there's so much cortisol that's been demanded over time that now they have a really low cortisol, the HPA axis firing. What we see is her HPA axis is still working. However, she's got a relatively higher amount of free fraction than she does her metabolized cortisol. So she has a certain amount of free fraction that may not be being utilized because this is the urine sample. It's being peed out. It's not being used, even though she's producing relatively a little less than how much is being produced. But then we like to use the example of this being the bank account, and it's quite high, although if it's a 19-year-old female, it's going to be higher than where it should be, right? Because she should be 3,000. So what I would say is sometimes people look at something called pregnenolone steal and say, when your adrenals are demanding for cortisol response because of a stress response, the brain signals to the adrenals to make cortisol and at the expense of making the sex hormones. But a lot of the times what happens with certain females is the hormones being released by the pituitary, the ACTH, not only stimulates receptors in the adrenal glands to produce cortisol, but it stimulates receptors in the adrenal glands to produce DHEA. And that's what you're seeing here. You're seeing that be a big demand for androgen production under stress. And some females just have that predisposition, especially when you measure that with genetic susceptibilities. Making sure genetic test is really, really important. Looking at some of the hormone imbalance type genes that you want to look at. Also understanding dietary implications. Are they eating lots of glucose and sugars and waiting long time between meals when they're not eating? What other inflammatory things do they have that's causing the pituitary to release signals to cause the adrenals to make a lot of hormones, not just cortisol, but DHEA. So we see that. Let me erase those things. And then we also see, let me erase that. So how do I erase that? So we're just going to erase those things. Then we also look at the female hormones, or not even just the female hormones, but we look at the sex hormones. And we can see her E2 is really high. We can see her testosterone is really high. And then her progesterone isn't quite as high. And really, that would be a problem where we could maybe do if she wasn't having a cycle. And actually, when we started working with her, she started having her cycle. But if her progesterone was a little lower in the second half of her cycle, when her progesterone should be high and her estrogen should be low, we would be concerned, and we may want to do a cycle mapping test. But ultimately what we see is we see a good rhythm, we see optimal free cortisol, we see the HPA axis starting to be inhibited, we see way more production of the DHEA from the ACTH that's being released from the pituitary because of stress, inflammation, emotional, chemical, environmental, and causing the estrogen to be super high and causing testosterone to be super high. I'd also be thinking about how well is this person clearing out things? What's the liver like? Do they have a challenge with clearing these things out? Then we go to the page where we look at the metabolites. So we can see her DHEA is really high, her testosterone is really high, and so are her androgens are very high. They're all too high. And her 5-alpha reductase is upregulated. We'll see that happen a lot of times when there's a stress response. 5-alpha will be upregulated. In fact, that's one of the characteristics of someone who has a PCOS-like symptom or presentation is they have an upregulation of 5-alpha reductase. It's more androgenic. We start seeing facial hair, oily skin, irritability, rage, male pattern baldness, abnormal cycles in their period, androgen excess, all that type of stuff. We also see her estrogens being really high, and there's a likelihood that she's actually aromatizing for the same reason that her adrenals would be causing her pituitary would be causing her adrenals to make more cortisol and more androgens would be the same reason that her 5-alpha is upregulated and would be the same reason why she would potentially aromatize and convert more estrogens. And that's what's happening. Now, a lot of people want to go on aromatase inhibitors, but it's not fixing the mechanism as why. What's the inflammatory stress? Is there a histamine issue? Is there environmental chemicals? Is there toxins? Is there pesticides and sprays? Is there pathogens? Is there glucose imbalances? Is there physical emotional traumas? All of the above is, that's why you got to ask questions. Very, very important to ask questions. But anyways, what we're looking at here is phase 1 and phase 2 of estrogen metabolism. And it should really look like this pattern here. So she should have 68% coming down this healthy pathway, and she's got 62%. She should have 7 to 11% coming down this unhealthy pathway, and she's got 13.8%. But because she's got so much estrogen to clear out, she is, even though relatively she's only a little bit higher than the 4-OH pathway should allow, she is a lot higher than the upper limits. And that's a big problem because that can create a reactive quinone, which will deplete your glutathione reserves and create cancer-like problems. So right away, we may want to get her on some DIM or I3C, which would ultimately push these excess estrogens down the pathway into 2-OH. Now, I've had a lot of women that are on DIM, but the problem is that they're very low with their estrogens, and yet they may be going down these pathways at a higher frequency, and the DIM would be helpful to have them go down more the protective pathway at a higher rate. They're depleting what little estrogen they already have. So I wouldn't recommend DIM in that instance. I'd recommend it when it's really, really high. But it brings us back to the original problem. What's the stressor? What's the inflammatory problem? Is it chemical? Is it environmental? Is it dietary? Is it all of the above? Let's address those things so we don't have so much aromatase activity, we don't have so much adrenal activity from the pituitary, and we're slowing down all of the above. Hopefully that made a lot of sense. But we have to make sure, we want to make sure our glutathione is on board so that we can ultimately support that pathway that's overflowing at the bucket. If we look at her phase 2, her phase 2 is really great. It should be at least 50% of phase 1. Now it says COMT or methylation is a nutrient or is a process. That's why we need to see the genetic component to see how well she's clearing out her metabolite, her phase 1 metabolite, which she's doing a great job of. But one thing that I learned actually from Dr. Carrie Jones, which I thought was pretty amazing, which I didn't know for a long time, if we look at, even though her ratios are pretty good, I mean, we'd like to see this be a little lower and this be a little bit higher. What's going in and what's coming out is a big difference. Like if you add up 46 and 7, we got 53, and then you add up another 32, 53 and 32 is 85, right? That's 85 going in, and then we have 4, so 81, 2, let's say 79, 10, 69, and 8, 61. So she's got a lot of estrogen going in and not as much coming out. So that's going to create a lot of oxidized, partially metabolized, receptor site binding jam up, even though her phase 2 looks good, right? So really we want to lower that estrogen burden, and that's a real huge thing we got to look at. So in this case, I'd probably want to look at lowering the testosterone down the 5-alpha pathway. Certain things you can do like chrycine, zinc, damiana, saw palmetto. Those are good things that can really lower that 5-androgen excess. Some DIM would be really good. And also maybe still wanting to support phase 2, depending on what genetic susceptibilities that I see there. And then lastly, we look at the last page, and we saw these values on the first page. We saw that her DHEA was really high. We saw that her free fraction of the cortisol, or her metabolized, was starting to come down. But we also see that her body is preferentially preferring twice. Ultimately, what we see is her body's preferring to make cortisol versus cortisone. And I'd be thinking, why is that? Why does her body want the active hormone versus the Army Reserve? Because it's still under stress. So we got to do things that control that stress response: mindfulness, breathing, movements, meditation. Those are things that can be really important to lower that free cortisol into cortisone. And then we could also look, if she's not sleeping, we can be thinking about things like magnolia, scutellaria, zispis root. Tranquinol was a nutrient that I really like by PRL. That would be really helpful for that, if that's a short-term thing, right? I mean, I could recommend short-term things here. And then lastly, we like to look at the some of these organic markers. So she's at the high end of B12, which means she's probably depleted. Candida, yeast overgrowth, maybe one of the reasons why her DHEA is so upregulated. You see that with a lot of females. They've been on antibiotics, they have a sweet tooth, they have lots of times during the day where they're not eating, they eat mostly carbs. And that can really cause a problem with candida yeast overgrowth, which would cause a slowdown of your recycling of B12, which would then cause oxidation of B12, which would then cause depletion of B12, and that's what we're seeing there. We're also seeing that her glutamate, her pyroglutamate, glutathione marker is in range, which I'm surprised about, but I would be thinking about maybe she's not releasing her glutathione. Does she have NRF1 or KEAP2 enzyme challenges where she's not able to stimulate the releasing of glutathione, even though it sort of pseudo looks good? Maybe we're getting some challenges with that, and it's not actually releasing. Then we see she's above the range in dopamine and vandomandulate. That would make sense. She's under stress. Her body's oxidizing. She's producing way too much androgens. She's putting a lot of pressure on her estrogen clearance. It's not getting out effectively. Maybe there's candida and yeast overgrowth. And we kind of start to see a picture here. And then lastly, it's nice to see that her 8-OH-DG was not elevated, because if you remember, we saw that she was producing a lot of 4-OH, which is a prerequisite for that 8-OH. So she is making good glutathione. There's some good gains there, which we're really happy about. But, you know, so bottom line is we started working with this individual. She started having her cycles back. The other things you need to look at, you know, which was, you know, characteristic of this particular case, was the fact that she had iron issues. She also doesn't eat a lot of, she's a vegan, which can make, again, that B12 problematic if she's producing a lot of oxidized cells that aren't being utilized. Anyways, lots going on there. Make sure you watch this again. My name is Dr. Joel Rosen. I am the Adrenal Fatigue Recovery Ninja. Make sure that if you have a daughter that's dealing with a PCOS problem, or you yourself are dealing with a PCOS problem, you comment or reach out to me, because I don't know too many people that put together these puzzle pieces and just say, hey, let's put you on a spiral nalactone, or let's put you on an antibiotic, and let's just put you on aromatase inhibitors, and let's just kind of go and put you on birth control, and let's just fix it that way. When you can get so much information by looking at blood work, looking at functional ranges, understanding the genetic component, and looking at the Dutch test, and really getting amazing results. So my name is Dr. Joel Rosen. I look forward to ending your PCOS nightmare. Have an awesome day.